Hello and welcome to this author interview. This is Howard Bachner, Editor-in-Chief, and I have the remarkable privilege of being joined by Maurizio Ciccone from Italy. Maurizio is a colleague who I've known for the last 5 to 10 years via Derek Angus. Maurizio, thank you for joining me today.
Hi, Howard. Thank you for hosting me.
So before we start, just a couple comments, and then we'll start the probably 35-minute interview. Firstly, from the JAMA family in editorial and publishing, and I think all of our colleagues in the United States, we know it's been an enormously difficult time in Italy, particularly in your area, and we wish you the best. And I thank you for taking some time out today. You're in our prayers.
Yeah. Thank you. We think it's important to share what we see here.
So, Maurizio, you've written a viewpoint that's being released simultaneously with this live stream. It's entitled Critical Care Utilization for the COVID-19 Outbreak in Lombardy, Italy, Early Experience and Forecast During an Emergency Response. We're going to walk through the viewpoint and some other things you've sent me, but before we start, I know you want to recognize your two co-authors and the entire team of people providing care. So could you just talk a bit about them?
Yes, so I've written with this viewpoint with Giacomo Grasselli and Antonio Pesenti that are there on the authorship, but this is an effort really that is being made available by the whole ICU network in Lombardy. And I think I will tell this probably later, but I think the only way that we've been able to act so fast is thanks to the fact that Alberto Zangrillo from San Raffaele Hospital in Milan and Antonio Pesenti from Policlinico Maggiore in Milan, they set up a network of intensive care that is always used to support patients with respiratory failure or cardiac failure with VV ECMO, VA ECMO. And that starting point was crucial for us to be able to manage the very, very first surge. So that was really the beginning of the framework of our network. And I think without these individuals, we would have been even in a much worse position than what we were on day one.
So just to help orient people, where is Lombardy in Italy and why is it so unique?
Well, Lombardy in Italy is in the north of Italy. It is probably one of the richest regions in Europe, not just in Italy. It is where the majority of the wealth and the global domestic product of the country is made. So actually we are even in a unique situation here because we are facing an outbreak in what probably is the part of Italy that has the highest concentration of resources and healthcare resources compared also to other parts of the country, and I would say probably also to some other parts of Europe.
What are the largest cities in this area?
So largest cities in this area, of course, Milan, and then other big hubs are cities like Bergamo, but it's a very dense area. I don't know if you've ever seen those maps that come from satellites where they looked at how Europe looks at night, and you can see that the density of light that we have in all Lombardy and going to Emilia-Romagna down to the east coast of Italy, it makes you understand how dense the population is in this area. And I suspect that probably was one of the reasons why we've seen these some of the outbreaks coming up here so fast.
So you were kind enough to send me an infographic this morning, and I'll just tell people what's on it. I don't know if we can show it. As of yesterday, close to 14,000 cases, 13,882. 1,116 health workers have contracted COVID-19, and there's been 803 associated deaths, which is a case fatality rate of 5.8%. We will return to that because I don't want to leave people with that figure. I think people really need to recognize the data from Italy are enormously consistent with the data from Korea and China in the sense that people under 60 are at incredibly low risk for fatality. So we'll return to that. So the story starts February 20th. That's the first sentence in the viewpoint. On February 20th, 2020, a 38-year-old patient admitted to the intensive care unit in Lombardy tested positive. So what happens after February 20th?
Well, you have to imagine that up to that moment, Italy was monitoring, as every other country in the world, very carefully what was happening in China, and every possible case that was identified through index cases was quarantined. People were followed so that we were really trying to contain completely the disease. So that day is a very specific day because one of the doctors in one of the hospitals that is being majorly affected, one anesthetist actually, realized that there was something different from a young patient that was not responding to a typical pneumonia. And this young patient didn't really have the normal risk factors for which we would screen for the new virus. So anyway, they decided to send a swab for it, and the swab was positive. Now, you can imagine that now we are in a situation in which a secondary transmission of a young patient that is so sick, that is in intensive care, is patient number 1. And we have to try and find the trace back whoever was in contact with this patient. So that was really the beginning of us getting a little bit nervous here in Lombardy and in Italy. And you may remember then during the next day, some other cases were coming up because finally we were testing more and more patients. So the risk factor had changed. It was not anymore traveled from China in the previous 14 days or being in contact with a confirmed case. It was actually being in contact with our patient in that area. And I do remember an anecdote of mine that I was actually in Switzerland at the time giving a talk for a symposium, and just by seeing the number of cases that were ramping up and being in contact with some colleagues there, I decided very quickly to come back to my hospital because we realized that we were having a secondary cluster, a secondary transmission cluster, and that is a key point to realize that this is very different from any other group of patients that was discovered in Europe up to the time.
How many cases began to accumulate on February 21, 22, 23, and then I know you have really reorganized your intensive care unit services. So how many cases were accumulating, and then how did you begin to think through the organization of your critical care services?
So difficult to give you the perfect number, but we were quickly seeing 5, 10, 14, and the number was going up kind of an exponential way from the very first day. So very fast increase. So the same on the Saturday, the network was called to get together. So the network of the hospitals that I was saying before, organized by Antonio Pesenti and Alberto Zangrillo, we got together and we say, we have a problem here, we have to act very quickly because it's very likely if the numbers that we see are coming up and the cluster has to be contained, at least try to be contained, it's very likely that we see more patients coming through. So it was very clear from us, and we were not alone. We had to work with health authorities and with everyone else, but we worked from the very beginning on 2 principles. Give intensive care to every patient that needs intensive care, and at the same time guarantee containment. Now, containment, you can do it in the community with a series of rules and maneuvers that can be done by health authorities and government and so on. But what you do in healthcare is try to find a way that the infection will not spread also to other patients. So we decided very fast that our only option at the moment was to ask hospitals, the first 5 hubs, to basically create some isolation units that could manage the initial surge. And at the same time, we realized that if really we were in the middle of an outbreak, we should have planned immediately an increase in capacity to be able to give intensive care to whoever needed intensive care and at the same time work on containment.
So how many hospitals exist in the Lombardy area? How many critical care beds were there? And then a week later, how many critical care beds were there?
So the total number of hospitals is not completely clear to me, but what I can tell you is that in this moment, hospitals that have an intensive care facility in which they have been able to create isolation units is more than 50. I think we're talking about 55 to 60 hospitals. Now, you have to imagine day 1 when the crisis started. The total capacity pre-crisis of the open ICU beds in the region was about 720 beds. Okay, so we're talking about probably 8 beds every 100,000 population. And these are beds that are usually reserved for the very sick patients. So in order to be able to manage the surge, we realized also that if the numbers were going to come up, we should have freed capacity as much as possible. So what we did was also, with health authorities, deciding to cancel all non-urgent elective surgery, free some capacity, and work very fast to realize our contingency plan was able to bring more capacity to the system.
So a week later, how many additional beds were you able to add to the area?
So within a week, we were able to add another 200 beds to the area. And that led us on the 7th of March to have roughly 360 patients treated in an intensive care bed at the moment. I can give you an official news from this morning, just from the coordinating network, that we've treated more than 1,000 intensive care patients so far since the beginning of the outbreak, and we are managing between 750 and 800 beds of intensive care patients occupied by COVID-19 positive patients in the moment while I speak.
Now, I know there may be some variability in this question, but the China data suggested that people could come into the hospital and be hospitalized and then deteriorate after 3, 4, or 5 days. Is that what you're seeing, or are people coming in through the emergency department and are they sick immediately?
Well, we are seeing a very high variety of cases, and indeed, you don't have to expect to increase your surge capacity just for intensive care. You really need to manage the outbreak. I can give you the example of what has been done in many hospitals was to create completely different pathways for respiratory symptoms patients, so that you could actually find a way to detect if the patient is really a COVID-19 positive patient or not. And you will see a lot of these patients coming through if you have a cluster. So the majority of patients, they may come maybe with some mild disease. And in Italy, we have a code in our emergency department that goes from green, yellow, and red, depending on the severity. The majority of patients will still be green. And now we are even able to send them home. And if they don't require hospitalization, but we know that they are positive, we will find a way for them to self-isolate. But they don't come to the hospital. For the ones that are kind of yellow and they require hospitalization, well, we see that these patients, they may require significant support. And indeed, when I talk about intensive care beds now, we are basically talking almost entirely about patients that are invasively mechanically ventilated. So we're talking about a very sick group of patients. On top of that, to increase our capacity to provide organ support, we have increased also the ability to provide a level 2 organ support, like monitoring and non-invasive ventilation outside of a normal ICU area.
There's quite a few clinical questions coming in, and I'll ask the one that I'm asked every time when I do interviews. Can you say anything about children? I have already mentioned that you were kind enough to send me the data from yesterday. And just to reassure people, case fatality rate for individuals from 40 to 49 is 0.1%, which is very similar to flu. 50 to 59 is 0.6%. Those numbers look very much like Korea. And then the break point begins to be 60, 70, and 80, and we'll come back to that. So that really is around comorbid conditions in the people who are older. But have there been sick children, and how have they done?
So two answers about age, since you're asking me both about children but also younger patients. So yeah. I'll answer first about children. In this dramatic situation, one good thing, at least that we see, is that kids seems to be infected, and we have some reports of infected kids. But it's almost zero, the percentage of very sick kids that we see. So we've not seen a significant surge of seriously ill kids. We don't know how that is happening. It's very consistent with the data that we were seeing from China, and kind of way in this very difficult situation is kind of reassuring. We don't know what's protecting them from getting very sick, but the good thing is that when kids get infected, they don't seem to become seriously ill. On the other hand, while the percentage of people that are younger seems to be having a better outcome, remember that the mean age of our population in intensive care seems to be around 65 years of age. So that means that half of the population is less than that, and I would consider that still relatively young. And so even we see in our units now, considering the large number of cases, we still see some young patients coming through. The majority is people that are older, but we see some young cases coming through.
Are the younger patients, 30, 40, doing fine, doing well after they get the treatment that they need?
Very early to tell you that, but that's what we are certainly seeing at the moment, and the reports that I can give you from my colleagues. Even patient number 1 had to go through quite a prolonged ventilation, but we know I have some reports from some news that actually is doing better. And that's what I'm seeing also in my unit. So from that point of view, we don't see something very different from other types of pneumonia. The older, the more frail, the more comorbid you are, the more likely is that it's going to be very difficult for you to come out well from intensive care. The younger you are with less comorbidities, well, if you come to intensive care, you have a higher physiological reserve, and the chances of coming out are probably higher.
Yeah, similar to data before and similar with other respiratory diseases. Have you created separate ICUs for those that are COVID positive versus those that are COVID not positive or need other types of treatment? Have you separated those types of ICUs?
Yeah, we've tried to do that as much as possible. That for two reasons, because we wanted to protect other patients from not being exposed to these patients, but also to maximize the way we're using our workforce. Remember that our mission, even if it's not written there, but is to provide an intensive care bed to whoever needs an intensive care bed. And we're not making any distinction between a COVID positive patient or a patient that is having a trauma, a patient that is in a car accident, a patient that is having an MI and require an emergency intervention. So during this time, we were very focused in guaranteeing all the emergency that is needed. We're still doing that. So we wanted to protect with different flows of patients through the hospital what was the surge of sick COVID-19 positive patients and all the other patients. So we separated as much as possible the cohorts. What has been really overwhelming in this sense is that the number of patients has been growing day by day. And what we found is that, for instance, in my hospital, but I know it's common experience in every other hospital, every day you make the plan for the next 2 days, but you need to have a couple of options ready for the next 5 days. You don't have to leave anything to chance. You have really to be prepared for the next surge and to guarantee everything that is time dependent that needs to come to your intensive care unit.
How are you protecting your staff? What have you done around staffing and protecting healthcare personnel? I think many people in the U.S. have talked about two groups that are critical to think about. That's the frail elderly with comorbid conditions, and it's critical that we maintain safety and health of our healthcare workers. So what have you been doing around staffing and your healthcare workers?
We've worked really, really, really hard from the very beginning, not just in buying and stocking personal protection equipment, but also to do a lot of training. So, for instance, what we've done in many places is increase as much as we could education and simulation and training in donning and doffing procedures. Remember from previous epidemics, a very key point is how you protect yourself, not just while you're working, but for instance, when you do the doffing procedure, which is where a lot of the contamination could be. So different solutions in different hospitals. What I've done in my hospital was to set up a simulation team from the first day when we were trying to set up our first unit. And what we did was train very fast 80 people in working protected, in working in difficult situation that you're not used before. We decided to go for a very high level of protection, even higher than what the WHO was recommending. The reason was that the very first beginning of the outbreak in Lombardy, remember the outbreak was found in this intensive care in the hospital, and we found a significant percentage of healthcare workers were affected, so were infected. So we really wanted to protect our intensive care, our hospital staff as much as we could. So we decided to go for Weber Vexillol close contact of less than 2 meters for FFP2 and above and N95 and above. And then depending on what you do with the patient, different types of protection from full cover to waterproof gowns and so on. In my unit, we are working with full protection now for these patients. That makes it difficult also to staff because if you could imagine working for 6 hours, it's very difficult to work for more than 6 hours in a shift. With this, you cannot even go and have a rest. You cannot drink. You cannot go to the toilet. So we are basically drinking 1.5 liters of water before dressing up. and then we try to work, and then you stop and you do something else and somebody else come. There are some more extreme situations where some people are not even able to do that, and people are really working very long hours trying to protect themselves as much as they could. But we do believe that it's so important to protect the healthcare workers that we don't want to go down on this standard. We owe it to our healthcare workers, but we owe it also to the patient and to the outbreak. We cannot afford to actually have people in quarantine or to go away from this. So it's a very, very important topic, and I really would give the message to everyone is you have to start to think now and make sure the training is in place. Stock is not just enough. You need to learn how to work with this protective equipment.
Are you allowing the healthcare workers to go home from the hospital?
Yes, we are, of course. It's very difficult to send them home, I would say, because no one has been summoned to work yet. But really the sacrifice that people are seeing is something incredible. We are doing an enormous effort to work, and I would like to say this is not just about intensive care. To save a life of an intensive care patient now is the effort of the whole hospital, of the all healthcare authorities, of everyone that work in healthcare. Everyone is working beyond what was asked to them, and so we do very long hours to cover the shifts. But so far, actually, it's incredible how united the group is to try to work, to protect themselves, and to give everything that we can to our patients.
Now, Maurizio, this is a difficult question. There's been disturbing reports over the last day or two in the American newspapers about, because you've run out of certain types of facilities, largely intensive care unit beds, you're having to make painful decisions about triage. Are those accurate, or has that not been your experience?
No, the only thing that we decided to do was really, as I said before, to give an intensive care bed to whoever needs an intensive care. And we don't want to do anything differently. Of course, we need to help the citizens and of the government to slow down the virus transmission, because we could be on our knees very soon if we see more patients coming through. But at the moment, we are giving intensive care to whoever needs an intensive care bed. And indeed, every day we end up with more intensive care beds than what we could have done the day before. Remember that pre-crisis, we had 720 open beds. Today, we've exceeded, just with COVID-19 positive patients, that total capacity. We are not giving up, and we are now thinking about even other possible solutions. So while we are increasing intensive care in every operating room where we can do that, we're even thinking about building a fast pace, a massive intensive care facility in the region where we can maybe bring some more capacity to the system.
Now, you're an intensivist and you take care of these patients. Most of it has been around respiratory disease, but there's a number of questions about, have you seen the traditional other medical concerns, hypertension, cardiomyopathy? Is there, you have a wealth of experience. Is there anything unusual beyond the respiratory disease?
So let me first start with the respiratory disease, because it's very interesting. The pattern is very recognizable for this patient. They come hypoxic to the hospital, and there is very severe hypoxemia, but they seem to have a good compliance. So they don't seem to be fatigued at the moment. They're able to breathe. And indeed, hypercapnia is not a problem. It's severe hypoxia. Mm-hmm. When we intubate and we ventilate them, we see that pattern carrying on, at least for the first days. And what we see is that the hypoxia is very severe. We see PaO2 and FiO2 ratios that are very low. But again, pH and hypercapnia is not usually a problem. Indeed, the compliance seems to be pretty good. They seem really to behave as pneumonias, to which you have to give a little bit of time to the lung to rest. In the large numbers that you see, you will start to see some other types of organ failure. For us, it's too early to give you comments on other things, as they may have seen in China. In a webinar that we did with Bindu at ASIC, for instance, was reporting a significant percentage of patients with myocarditis or with cardiac dysfunction. We don't seem to see that as much here. And indeed, I would say that the majority of organ failure is related to respiratory failure. Some patients, they may require renal replacement therapy, but we've not seen significant other organ dysfunction, of course, as you would see normally in an intensive care patient with pneumonia. But really, the predominant clinical picture is a severe respiratory failure from the pneumonia from this virus.
And any unusual therapies being tried, or have you just tried to use the traditional approaches to acute respiratory failure, well known, well practiced for decades now?
So I would say the only evidence that we have at the moment is that we can do supportive care for these patients. So that's why our mission is to provide a bed to whoever needs an intensive care bed. Of course, there are reports coming out everywhere. There is a lot of anxiety, understandably, in physicians. Everyone wants to find a specific drug for this patient. I say that probably I don't think there is any specific drug at the moment. I particularly enjoyed, Howard, your podcast with Anthony Fauci the other day. I think it explained it so well that even in a moment of stress like this one, our enormous effort should be to do the things that have an evidence and to do the things that can really help our patients. So I can speak for myself and for many people in the network. We believe that that's where the effort has to be. We need to find ways to support more patients if they come. I don't think we need to take shortcuts in therapy, just using therapies that are available just because they are there. We don't know if they could be dangerous. So adjunctive therapies may provide benefit, but maybe they could even be harmful for our patients. I think especially with this volume of cases that we see, we need to do simple things that we know how to do well, and we know how to do well intensive care. We know how to ventilate our patients well. This is what we are best at. All other therapies are something that we would consider if we find ways to test them safely in a research fashion with rigorous methodology, then I think we should do it, and I don't think we should lose time to do it, but I don't think we should take shortcuts with adjunctive therapies that have no evidence.
There's so many questions coming in. I think, you're such an astute clinician. People really want to hear from you. Do you have a few more minutes, Mauricio?
Yeah, of course.
Wonderful.
I think this is important.
Thank you. There's been quite a few questions about reinfection. They've emerged in some of the literature. Someone who goes home gets reinfected. Have you seen much of that, or is it too early to know?
It's what is being incredible about this event personally is that it feels like 2 months we've been fighting this, but actually it's not even 3 weeks. So I think it's too early for us to talk about that. What we are doing to try to protect the population, we don't know what is the evidence out of it. But I come back to the question about labs. We used our labs in a way that we wanted to prioritize patients that need intensive care to be correctly identified. So we had a protocol to identify them early and to have a fast-track process on that. And at the same time, when people get better, in order to send them home and to prevent them to reinfect maybe other people, we do 2 swabs, and if the 2 swabs are negative, we send them home. We really don't know if this is common sense and pragmatism, if there is any evidence for it, but this is what we're doing.
I'll return to some more questions, but I just want to make sure I touch on this. You now have as much experience with this as anyone in the world. What are your recommendations for the United States?
I recommend everything that we recommended from the very beginning to everyone, and we even sent a letter with the European Society of Intensive Care Medicine on this. Don't underestimate this. This is not a normal flu. This is serious. The majority of people that get infected will go through it normally, but the percentage of patients that get infected and requires hospitalization is high, and the percentage of patients that require intensive care admission is high. So do not underestimate this. Get ready with your surge capacity in hospital. Make sure that you work on the protocols now. Make sure that if an outbreak comes, a cluster comes close to you, you don't lose time by putting the plan in action. I think that's very important. And do not think that you can win this battle just by increasing your capacity. Containment, mitigation maneuvers, slowing down maneuvers are equally important, if not more important, than anything that we can do as doctors. We want to fight, and I really think this is something I would have never imagined to face in my life, but this is something that we're going to win with governments, health authorities, and with citizens. If the moment comes where your government in the US or in any other country mandates self-isolation or any other maneuver, I think it's the personal responsibility of every citizen to do that. Because if you don't take down the transmission of the virus, then the capacity of your system will be overwhelmed.
Do you have any sense over the last few days? I mean, the reports out of China, Korea, have suggested a waning of the number of individuals being infected. I think we can debate the aspects of the massive quarantine in China, but given that Beijing and Shanghai were generally spared, it's hard to imagine people not thinking it had worked, even if it could be seen as being draconian. It appears to have spared over 1 billion people. Do you have any sense yet of what's happening both in Lombardia in terms of daily number of cases versus the rest of Italy?
Look, we have to be realistic. The incubation period of this virus is up to 14 days. So we are basically bracing for, even a higher peak of what's coming here. We know, we are expecting it. The lockdown of Lombardy happened a few days ago. The lockdown of Italy just happened. We have to be prepared for a peak that probably is not going to slow down immediately. So we're still expecting for the next 2 weeks to be ready to give any support to patients that may increase in numbers. And I believe and I hope that after 2 weeks, we will be able to give you better news.
One more clinical question, then a couple other questions. The type of ventilation for acute respiratory stress is highly variable, and sometimes you don't need the traditional ventilator. And there's now been concerns that the U.S. may not have a sufficient number of ventilators if we end up being faced with the same type of cluster outbreak that you've had. Has there been different approaches to ventilation, or just the traditional varying approaches, and see what works with each patient?
So I tell you what we've done here, which is basically using every capacity on ICU ventilators that we have. But remember that there are ventilators even in the operating rooms, and there are in many places more operating rooms than ICU beds. And indeed, the responsibility of the government was also to try to stop elective surgery. That allowed us to free ICU beds from surgical patients that need intensive care, but we also freed a lot of resources from our theaters, from our anesthetists that could help. We are also using non-invasive ventilation, right, and we try to be very, very pragmatic about it. I think patients that respond to non-invasive ventilation, we don't see that they get tired. We will keep them on that. We don't want patients to get tired on non-invasive ventilation. The feeling is that if you exhaust someone on non-invasive ventilation, they may require longer time on an invasive ventilation. But we have to use everything. And indeed, we have increased massively also the capacity of non-invasive machines in our hospitals.
As you know, there was a back and forth last year article in JAMA, the Bayesian analysis about ECMO following the NEJM report. And I think there's a general feeling that ECMO does work. Have you used it in many patients, or are you limiting it?
Well, it's not that we are limiting, but what we are saying is that this is a problem of volume of respiratory failure that responds usually pretty well to simple techniques that have been studied and validated over the years. So we use quite a lot of proning, and we use, protective lung ventilation. With this, if a patient has some physiological reserve, we see that they can do better. We are reserving ECMO just for very selected cases. We do believe that in this moment, the focus should be really on providing high quality volume therapy for the large volume of patients that we see.
And just returning to one question about healthcare workers, and in this case, specifically physicians and nurses. When you go home, how are you protecting your family?
Well, I can tell you what I've done personally. When the outbreak started, my kids were on holiday, and then they stopped on holiday with my parents. And my parents, they don't live in the same region as mine. I thought, I'm a doctor, I'm a citizen as well. My parents are old, so I decided coming from Lombardy, I will not see my parents for a bit. So basically, I decided to self-isolate that. For the people that live in the same place, there is no reason to panic on this. If you become a close contact or you think you've been contaminated, there are some very robust policies that the health authorities have put in place. For instance, if something like this happens, if you get symptoms, you will get a swab. If you don't get a symptom, they will ask you to spend some days trying to avoid to spend time in close contact. If you can, try to use a different bathroom, a different bedroom. Of course, we are concerned. But we cannot panic. We have to be sensible, and we have to use the recommendations. The recommendations may change over the days. The communication needs to be clear to everyone. so that you can protect yourself, your families, and your patients.
So Mauricio, I actually know who you are since we're friends and colleagues, but can you tell our listeners who you are?
So I am Maurizio Cecconi. I am the professor of anesthesia and intensive care medicine at Humanitas University in Milan. I'm also the head of anesthesia and intensive care at Humanitas Research Hospital, and I'm also the president-elect of the European Society of Intensive Care Medicine.
From JAMA and the United States, all of our colleagues, we are praying for you. You've done extraordinary work, and I can't thank you enough for sharing the clinical experience you've had, the information about healthcare workers, and really an intimate view of what's been occurring in your area. You and your colleagues have done an extraordinary job, and you're saving thousands of lives, and obviously you're to be commended for it. Mauricio, thank you so much for joining me. This is Howard Bachner, Editor-in-Chief of JAMA. We will continue to bring you these podcasts, and everyone, thank you for watching and listening. Mauricio, be healthy, be healthy, be healthy.
Thank you. We will keep sharing everything that comes out here.
Thank you.